Hello, I'm Dr. Joel Aquino. I am an addiction psychiatrist, clinical neuroscientist, and assistant professor of psychiatry at the Yale School of Medicine, where I lead an NIH-funded lab focused on developing novel treatments for pain and substance use disorders. Today, I'll be discussing the complex intersection of chronic pain and alcohol use disorder, two conditions that frequently co-occur but are often overlooked in clinical settings. To start, let's define our key terms. Acute pain is typically short-lived and usually arises as a direct response to an injury, trauma, or surgical procedure. It's a signal from the body indicating tissue damage and often subsides as healing occurs. Chronic pain, on the other hand, is much more than an extension of acute pain. It lasts for more than 3 months and can persist even after the original injury has healed. In many cases, there are no clear signs of ongoing inflammation or injury. This type of pain involves biopsychosocial factors that amplify its impact, embedding it within the nervous system. Biologically, nervous system sensitization can increase pain sensitivity. Psychologically, factors like depression and anxiety can worsen pain perception. And socially, isolation or lack of support can intensify the pain experience. Together, these factors affect not only physical sensation, but also emotional well-being, quality of life, and daily function. Alcohol use disorder, or AUD, is a medical condition where a person's drinking leads to distress or harm. It's characterized by an inability to limit alcohol intake, needing more alcohol over time to achieve the same effects, a phenomenon known as tolerance, and experiencing withdrawal symptoms when not drinking. For individuals with chronic pain, alcohol may seem like a coping tool, offering temporary relief at high doses due to its pain-relieving properties. However, this relief is short-lived, and tolerance quickly develops, requiring more alcohol to achieve the same effect. This cycle not only increases the risk of developing AUD, but also worsens pain and other health issues over time. Chronic and severe alcohol use also directly contributes to pain through its effects on multiple organ systems. For example, it can lead to peripheral neuropathies, chronic pancreatitis, and pain associated with injuries or trauma. As physical dependence grows, withdrawal from alcohol can lead to hyperalgesia, heightened sensitivity to pain, further complicating pain management and creating a cycle of increased alcohol use. Patients living with both AUD and chronic pain frequently experience intensified pain, emotional distress, sleep disturbances, and reduced effectiveness of other pain treatments. This complex relationship between chronic pain and AUD makes managing both conditions challenging and highlights the importance of integrated care. Effective treatment for patients with co-occurring AUD and chronic pain involves a comprehensive approach that addresses both conditions. Medications like naltrexone and acamprosate can reduce alcohol craving and support recovery in aiding pain management. Gabapentin, though mixed in its effectiveness for AUD, has evidence as an analgesic for certain types of pain, particularly neuropathic pain, at doses between 600 and 900 milligrams 3 times daily, while topiramate addresses both AUD and migraines. Serotonin norepinephrine reuptake inhibitors, or SNRIs, such as venlafaxine and duloxetine, are beneficial for certain chronic pain types, such as fibromyalgia and neuropathy, and are safe to combine with AUD treatments. Behavioral therapies, including cognitive behavioral therapy and mindfulness-based approaches, are crucial in helping patients understand the connections between craving, pain relief, and withdrawal. Patients can learn that cravings may not just reflect a need for alcohol, but also a need for pain relief, whether from physical pain or its emotional aspects. Recognizing these intertwined experiences can empower patients to develop tailored strategies to manage both conditions without relying on alcohol. Physical therapy can be particularly important for improving functional abilities, especially in patients with chronic low back pain, a common cause of disability and a frequent driver of unhealthy alcohol use. Through physical therapy, patients can build strength, reduce fear of movement, and improve mobility, ultimately helping to lessen the impact of pain on daily life. Physical activity tailored to the patient's capabilities, can also help reduce both pain and alcohol craving. The most effective approach combines behavioral and pharmacological interventions, personalized based on the patient's specific pain profile, current medications, and any potential side effects. Emerging experimental treatments such as ketamine, serotonergic psychedelic medications, and other novel compounds are being explored for their potential to address both chronic pain and AUD. These may offer new approaches to managing the complex interactions between pain and addiction, but are not ready for widespread use. In summary, chronic pain and AUD are deeply interconnected and require a holistic approach in treatment. As clinicians, it's vital to screen for both conditions, especially in patients with chronic pain who may be at risk of using alcohol as a coping mechanism. The key takeaway is to guide patients towards pain management strategies that avoid alcohol, which may offer short-term relief but ultimately worsens their condition. Providing effective alternatives and connecting patients to specialized care is essential. Thank you for watching, and let's continue to support our patients with comprehensive care that addresses both pain and addiction.